Hello everyone, good evening everyone. Hi, let's start the session. Let me just go back. Let's see if everyone's there. Yeah. All right, just one moment. All right, good evening Arjun, good evening Afia, good evening Videsh. First of all, this session is not enough. Let me be very honest. You can't cover pediatrics in 2 hours. That's but yes, it's going to be a good revision. If you've already done pediatrics, you can easily revise the most important topics of pediatrics over the next 2.5 to 3 hours, whatever the time session for the session is going to be. So I'm going to discuss the most important previous year question. If I go for pediatrics for the past 5-year papers, they were around 80 to 100. Around 80 to 100 MCQs, out of which I've chosen the most important 30-40 MCQs because when you go to pediatrics, you'll realize there are a few things they're asking again and again. So milestones are asked again and again. Kwashiorkor marasmus is asked again and again. Cystic fibrosis is asked again and again. MCQ management of dehydration and pneumonia again and again. Tetrology of Fallot again and again. So what I've done is I've clubbed all the question of these most important 7 to 10 topics of pediatrics. Alright, what are these most important 7 to 10 topics of pediatrics? This includes your milestones. This includes your MCQ management of dehydration and pneumonia. This includes your cystic fibrosis. This includes your tetralogy of Fallot. This includes your SAM, severe acute malnutrition management and management of Kwashiorkor and marasmus. All right, along with a little bit of neonatal resuscitation protocol, NRP, neonatal resuscitation, especially in the recent papers, NRP has been asked much more. Alright, all these, if you look at it, they cover around 50% of your pediatrics questions. They actually cover 50% of your pediatrics question. So if you're just looking to pass, if you're just looking like, let me just get 50% in pediatrics, this is a weak subject of mine, sure, then the session is enough. But it's always, I would rather advise you to actually go through my actual, if you had attended the DBMCI, the actual class, I would ask you to go through at least the first workbook, the first part of the workbook properly. Alright, but if I look at these 7 topics, if you look at it, they actually make up 40 to 50% of the pediatrics question. And so what I'm going to basically do is discuss the PYQs of these topics. Some new questions I'm also going to discuss which are derived from those PYQs, and we'll discuss those topics a little bit in depth so that at least 50% most important topics of pediatrics are done in this next 2.5 to 3 hours. Alright. So congenital neonatal jaundice actually is not that frequently asked. If you actually look at it, if someone is asking neonatal jaundice is actually not that frequently asked. It's asked one in, out of the 2 sessions, 1 session may ask question of neonatal jaundice, not necessarily both the sessions. These questions are almost like someone actually pointed it out. These are almost like short shots. Almost a given that they will be asked. Some question related to this is going to get asked. Alright, so I'm going to cover the short questions. Alright, is it enough? Obviously not, because short shots will make up 50% of the paper or maybe 40% of the paper. But at least 40-50% you will definitely get correct if you go through this particular session, and we'll provide you with the PDF at the end of the session. Okay, we'll provide you with the PDF at the end of the session. Let's start with the session. Alright, so what I'm going to do, very importantly, I'm going to discuss the question. I'm going to tell you the answer. Then what we are going to do, we are going to go discuss the topic a little bit in depth. For example, milestones, I'll discuss milestones properly in depth. And again, we'll come back to the question and see how the answer was there. So question asked, at what age does stranger anxiety appear? At what age does the stranger anxiety appear? Tell me the answer. Exactly. The answer is 7 months. See, at 9 months, object permanence starts. At 9 months, what starts? Object permanence starts. And child is able to say bye, bye, bye. Child is able to wave bye, bye. At 1 year of age, child is going to play a simple ball game. Or will kiss on request. And at 15 months, 2P starts. Child is going to point towards objects. Okay, that's an umbrella. Okay, that's the roof, that's the floor, something like that. He's going to point towards objects, and he will point towards his own wet pants. In case he has peed himself, he doesn't have bladder control at this point of time, but if he has peed himself, he'll be able to tell the parents, okay, I peed myself, please change my clothes. Okay, so he'll point towards his own wet pants. Alright, so the answer is going to be 7 months. How can you remember stranger anxiety is going to come at 7 months? Look at the word anxiety. Look at the word anxiety. Anxiety has how many letters? Anxiety has 7 letters in it. Anxiety has 7 letters in it. So stranger anxiety is 7 months. Anxiety has 7 letters in it. That's how you can remember. Let's see the next question. At what age does transfer of object from one hand to another hand occurs? The answer here is also going to be 7 months. The answer here is going to be 7 months. Is actually 7 to 8 months. It's actually 7 to 8 months. It's actually 7 to 8 months. Okay. So at 6 months, there is ulnar grasp. And at 9 months, there is immature pincer grasp. And at 12 months, there is mature pincer grasp. So at 6 months, what happens? At 6 months, what's going to happen? Let's assume some object. Let's assume this is there. At 6 months, this child is going to pick it with the ulnar aspect of the hand. If he's picking with the ulnar aspect of the hand, this grasp is not good. He won't be able to transfer objects from one hand to other. At 7 months, he will be able to pick it with the help of his radial thumb, or the radial aspect of the hand. So that is radial grasp. So at 7 months, when he's picking it up with radial grasp, he'll be able to transfer from one hand to another also. So radial grasp occurs at 7 months, and that's why at 7 months, the transfer of objects from one hand to other is also going to start. So transfer of object from one hand to another is also going to start at 7 months. Okay, at 9 months, you will have immature pincer grasp. At 12 months, you will have mature pincer grasp. I'll discuss this a little more in depth later. Now, let's look at this question. An anxious mother presents to the physician for evaluation of her 20-month-old baby. 20 month. Okay, 1 year, 8 months basically. Baby was full term. Okay. On examination, child is otherwise healthy. Good. While playing with his sister, her boy cannot make a tower of 6 cubes. He is not able to make a tower of 6 cubes. He is not able to use pronouns like I, me, you. He is not able to. He is not able to. Then the question is asking, at what age is a child able to make a tower of 6 cubes? At what age will the child be able to use pronouns? At what age is the child able to use pronouns? Basically, they are asking you what? At what age child is able to make a... He is 20-month-old. He is not able to make tower of 6 cubes. At what age you will make a tower of 6 cubes? And child is healthy. See, automatically you rule out 2 options. A 20-month-old is not able to make. So do you think 15-month-old or 18-month-old will be able to make a tower of 6 cubes? He's a 20-month and he's healthy. He's not able to make a tower of 6 cubes. Obviously, a 15-month and 18-month is not able to make that. So these 2 are automatically ruled out. Simply by logic, even if you don't remember, a 20-month-old child is not able to make a tower of 6 cubes. How will a healthy 20-month-old is not able to make a tower of 6 cubes? How will a 15-month or a 18-month will be able to make? So these 2 options are ruled out. The remaining option is 3 years or 2 years. And what is a mnemonic? A child of 2 years is able to make a tower of 6 cubes. He is able to make a tower of 6 cubes, and a child of 3 years is able to make a tower of 9 cubes. So at 36 months, you are able to make a tower of 9 cubes, and at 24 months, you are able to make a tower of 6 cubes. So the answer here is going to be 24 months. Answer is going to be D, that is 24 months. Alright, absolutely. Everyone is answering it correct. Absolutely. Next question, gonadal growth corresponds with. Gonadal growth corresponds with. See, gonadal growth, when does it occur? It occurs during puberty. It occurs during puberty. Now, brain maximum, 90% of brain growth has already occurred by 2 years. So when your gonads are growing, your brain is not growing. So this is incorrect. Skeletal system, this is correct. Skeletal system is correct. See, when puberty occurs, you also have a growth spurt. During puberty, you also have growth spurt. And growth spurt means there is increase in the skeletal system. There is skeletal growth. That's why your height is increasing. So the correct answer here is going to be option B, that is skeletal system. That is the correct answer. That is the correct answer. See, lymphoid growth occurs between 4 to 8 years. It occurs between 4 to 8 years. So that is not the correct answer to this question. That is not the correct answer to this question. So let's discuss the milestones a little more in depth. I'll go a little fast. Let's discuss the milestones a little more in depth, and let's again come back to the questions when we have discussed the milestones all over. We have discussed the milestones all over. All right. So first we'll start with gross motor milestones. Easy way to remember gross motor milestones. 3, 6, 9, 12. 3, 6, 9, 12. This is the easiest way you can remember the gross motor milestones. At 3 months, you will have neck control. At 6 months, you will have trunk control. So child will be able to sit with support. At 9 months, you will have knee control. So you'll be able to stand with support. At 12 months, you will have feet control. So you'll be able to walk with support. 9 months, knee control, you are able to stand with support. 12 months, feet control, you are able to walk with support. So just let's write that down. At 3 months, you have what? You will have neck control. At 6 months, you have what? You have trunk control. So you will be able to sit with support. You are able to sit with support. At 9 months, you have knee control. You have what? You have knee control. So you will be able to stand with support. You will be able to stand with support. And at 12 months, you have feet control. So you will be able to walk with support. You will be able to walk with. You will be able to walk with support. All right. Now, if at 9 months you are able to stand with support, you should be able to sit without support before that. So sit without support comes at 8 months. Now, if you are able to walk with support, you will be able to walk with support only if you are able to stand independently. So stand independently comes at 11 months, at 11 to 12 months. So at 12 months, walk with support will come, and stand without support will also come. And stand without support will also come. And stand without support will, this will come at 11 to 12 months. This will come at 11 to 12 months. Apart from this, 2 other things you should remember. At 8 months, child is able to crawl. When he is crawling, his all 4 limbs are on the ground. His abdomen is touching the ground. So at 8 months, crawling will also start. At 10 months, creeping is going to start. What is creeping? Now he's on all 4 and abdomen is lifted above the ground. So at 10 months, creeping is going to start. And the sit with support. When the child sits with support, he sits with support like this on his own hands. This is called a tripod position. This is also called as tripod position. So 3, 6, 9, 12. Neck control, trunk control, sit with support. 9 months, knee control, stand with support. 12 months, feet control, walk with support. At 9 months, you are standing with support. So 8 months, you should be able to sit without support. At 12 months, at 12 months, you are able to walk with support. So at 11 months, you should be able to stand without support. After this, it is very, very easy. After this, it is very, very easy. After this is very easy. Now, remember what did Bunny say to Naina in Ye Jawani Hai Diwani? मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. The child is going to do exactly the same. मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना. Obviously, he won't fly. He will be able to go up and down stairs. So, up and down stairs using 2 feet per step. So child is able to walk independently at 15 months, run at 18 months. At 2 years, child is able to go up and down stairs using 2 feet per step. At 3 years, 3 has 3 in it. Tricycle is also having 3 in it. So child is able to ride a tricycle. At 4 years, 4 has 4 in it. Hops also has 4 letters in it. So child is able to hop at 4 years. 5 years, 5 has 5 in it. Skips also has 5 letters in it. Child will be able to skip at 5 years. Now, as far as up and down stairs is concerned, at 2 years, child is able to go up and down stairs 2 feet per step. At 3 years, child will be able to go upstairs using only 1 feet, and downstairs he'll come still using 2 feet. But finally at 4 years, both up and down stairs, he will use a single feet. He'll use only 1 feet. So this is your gross motor milestones. 3, 6, 9, 12. Neck control, trunk control, sit with support. 9 months, knee control, stand with support. 12 months, feet control, walk with support. मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. 15 months walk, 18 months run, 2 years up and down stairs 2 feet. 3 years 3 for 3, 3 for tricycle. 4 years 4 for 4, 4 for hops. 5 years 5 for 5, 5 for skips. This completes your gross motor milestone. Now let's move towards fine motor milestones. Let's see what the fine motor milestones are. Let's see what the fine motor milestones are. Now at 3 months, when the child is lying down, if you child will bring both the hands into the midline and look at them intently. This is called hand regard. So at 3 months, child will bring both hands into midline. This is, and look at them intently, which is also called hand regard, At 4 months, if you hang something from that, he'll try to grasp it. This is called grasp with both the hands, bidextrous grasp. He will not be able to hold it. He will either overshoot or he will undershoot. So at 4 months, you will have bidextrous grasp. At 4 months, you will have bidextrous grasp, but overshoots. So when does bidextrous grasp start? The answer is going to be 4 months. At 5 months, this bidextrous grasp is complete. He will not overshoot. So at 5 months, again, he will have bidextrous grasp. No overshooting. No overshooting. At 6 months, this bidextrous, both the limbs will convert into single limb. So if something is in front of him, he'll try to hold it with the ulnar aspect, like I have told you. So at ulnar aspect, he will be able to hold it. So this is called ulnar grasp, which is a type of unidextrous grasp. At 7 months, he'll be able to hold it like us, like we do, from the radial aspects, radial grasp. And when he's able to hold like this, he'll be able to transfer from one hand to another. So at 7 months, you have radial grasp and transfer of objects. At 9 months, imagine this is a pen. If he's holding this pen like this, using only the index and thumb finger, this is called mature pincer grasp. Just this is mature pincer grasp. This comes at 12 months. Mature pincer grasp comes at 12 months. At 9 months, automatically what is going to be there? He'll hold the pen like this. He's using index and thumb finger, but still using a little bit support of his middle finger. This is called immature pincer grasp. This will come earlier as compared to mature pincer grasp. That will come at 9 months. So immature pincer grasp will come at 9 months. Immature pincer grasp will come at 9 months. Immature pincer grasp will come at 9 months. At 15 months, now he's holding the pen. Now he's holding the pen, he's holding the pencil. At 15 months, he'll start to do like this. This is called scribbling. So scribbling is going to start at, scribbling will start at 15 months. Then comes your drawing skills. Drawing skills are very important. They are very frequently tested. So coming to the drawing skills, at 2 years, how do you remember? At 2 years, 2 points. 2 years, 2 points. He's able to draw a straight line between 2 points. At 3 years, child is able to draw a circle. At 3 years, child is able to draw a circle. How will you remember it? You will remember it like this. That 3 has a circle inside it. 3 has a circle inside it. At 4 years, child will be able to draw what? Child will be able to draw a cross. Child is able to draw a cross. How do you remember it? Cross has a 4 in it. Cross has a 4 in it. At 4.5 years, child is able to draw a rectangle or a square. Child is able to draw a rectangle or a square. At 5 years, child is able to draw a triangle. Child is able to draw a triangle. How do you remember it? How do you remember the triangle? Like this. So 5 has a triangle inside it. 5 has a triangle inside it. So these are some important drawing skills. Coming to towers. Child is able to put one cube on top of another cube to make a tower of 2 cubes at 15 months. He is able to make a tower of 3 cubes at 18 months. He is able to make a tower of 6 cubes. Remember, 6 cubes is what was asked. This occurs at 2 years, and he is able to make a tower of 9 cubes at 3 years. How do you remember? 2 into 3, 6. So at 2 years, he is able to make a tower of 6 cubes. 3 into 3 is 9. He is able to make a tower of 9 cubes at 3 years. So this is how you can remember. This is how you can remember. 2 years, 6 cubes. 9 cubes at 3 years. 3 years, 9 cubes. 2 into 3, 6. 3 into 3, 9. This is how you can remember. Now we come to social milestones. Now at 2 years, child is able to smile. There is social smile. At 2 months, there is social smile. At 3 months, child is able to recognize his own mother. See, 3 months he was able to bring hand into midline and able to recognize his own hands, which I was calling as hand regard. He was able to regard his own hands. He should give regard to mother also. So this is how you can remember 3 months hand regard and mother regard. That is able to recognize his own mother. At 3 months, child recognizes his own mother. At 6 months, now you can remember by looking at the number in the months. See, at 6 months, there is 6 in it. Mirror. Mirror also has 6 letters in it. 6 months, mirror, 6 letters. Child has mirror play. So he'll sit in front of a mirror and play with play with his own reflection, recognize his own reflection and play with it, which is called mirror play. 7 months. Look at 7. 7 has 7 in it. So you need another word with 7 letters in it. That word is anxiety. Anxiety has 7 letters in it. So child will have stranger anxiety at 7 months. Let's look at 9 months. 9 has 9 in it. 9. So we need a word with 9 letters in it. Permanent. Permanent has 9 letters in it. Child has object permanence. What is object permanence? Let's say there is some object in front of him. Prior to 9 months, before 9 months, if you take the object away from him, out of sight, out of mind, he won't care about that object. But after 9 months, if you take the object away from him, he'll look around. Where has the object gone? Because now the object is permanent in his mind. This is called object permanence. This is what is called as object permanence. And another 9-letter word is bye. 9 letters. Bye. Child will be able to wave bye also at 9 months. At 12 months, that is 1 year, child will play a simple ball game. At 15 months, child has what is called as 2 P's. I already discussed these 2 P's. He'll point towards object and he will point towards his own wet pants. That is point towards his own P. He'll point towards object and point towards his own wet pants. Alright. At 18 months, 2 D's happen. At 18 months, what do happen? 2 D's will happen. At 18 months, what will happen? 2 D's will happen. What are these 2 D's? These are dry at day. So now he won't pee himself. He will be dry at day. He'll be able to tell the parents, I want to go to the washroom. Please take me to the washroom at day. At night, that is nocturnal enuresis can still occur, but he's dry at day. The second D is domestic mimicry. So mother is going to, do what? Mother will do, let's say mother is cleaning the house with a broom. Child will also pretend to be like mother, take up a broom or take up some object and pretend that he's also cleaning the room or cleaning the house. This is called mimicking the domestic task of the mother, domestic mimicry. At 2 years, 2 has 2 in it. 2 parallel lines. There will be parallel play. At 3 years, there will be cooperative play. At 2 years, 2 children, they will not play with each other. They'll play independently of each other if it's in a single move. So they're playing parallelly. At 3 years, they'll start to play with each other. That is cooperative play. At 3 years, child knows 3 things about himself. He knows 3 things about himself. What are these 3 things that he knows about himself? He knows his name, he knows his age, and he knows his gender. So at 3 years, child will be able to say 3 things about himself. मैं आदित्य हूँ, मैं 3 साल का हूँ, मैं लड़का हूँ. These 3 things, I'm Aditya, I'm 3 years, I'm a male child. These 3 things child will be able to say at 3 years of age. At 4 years, from cooperative play, instead of 2 children playing with each other, multiple children will play with each other. That is group play will start. That is group play will start, and even role play will start. And role play will also start. So this is your social milestones. Now we come to the language milestones. As far as language milestones are concerned, at 2 months, what's going to start? Vocalization starts. At 3 months, 3 has 3 in it. Coo also has 3 letters in it. So cooing will start. 4 months, ha has 4 letters in it. So child will be able to laugh out loud at 4 months. At 6 months, what's going to start? Monosyllabic babbling. Mama, ma, ba, da. Ma, ba, da. That is your monosyllabic babbling. That is your monosyllabic babbling will start at 6 months. At 9 months, this monosyllabic babbling will turn into bisyllabic babbling. This will turn into Mama, Baba, Dada. Mama, Baba, Dada. Like that. At 12 months, finally he'll be able to say one word with meaning. So 1 year, one word with meaning. One word with meaning. 15 months. 15 has 5 in it. So what will be the vocabulary? 5 words. 4 to 6 words. That is 5 words on an average. So 4 to 6 words will be the vocabulary, and child will have what is referred to as jargon speech. Child will have what is referred to as jargon speech. 18 months. 18 has 8 in it. Vocabulary will be 8 to 10 words. Vocabulary will be 8 to 10 words. Vocabulary will be 8 to 10 words. 24 months. 24 months, 2 years. 1 year, 1 word with meaning. 2 years, 2 word sentences. Child will be able to say what? Child will be able to say 2 word sentences like I go, you come, he goes. These are simple 2 word sentences. I go. And what is this I? This I is nothing but a pronoun. Instead of saying Aditya goes, he's saying I go. So I is a pronoun. So child will be able to use pronouns at 2 years. Child is able to use pronouns at 2 years. At 3 years, child is able to say 3 word sentences. At 4 years, child is able to say a story. Child is able to tell a story or a poem. Alright, and child starts to use past tense. So 4 years, past also has 4 letters in it. Child is able to say, use past tense. After past comes future. So at 5 years, child is going to use future tense. Child asks meaning of words. Child will ask meaning of words. Child will ask meaning of words. Alright, child will ask meaning of words. This completes our milestones. A little bit about growth. When a baby's growth, we will discuss how the weight and the length is going to progress. Alright, so at birth, the weight of the baby is 3 kgs. Let's assume this to be X. At 5 months, it will double. The birth weight will double. So baby will become 6 kgs. At 1 year, the birth weight will triple. 3x. So baby will become 9 kgs. At 2 years, it will become 4x. At 2 years, it will become 4x. That is, the weight of the baby will become 12 kgs. At 3 years, it will become 5x. That is, the weight of the baby will become 15 kgs. And at 5 years, it will become 6x. That is, weight of the baby will become 18 kg. Coming to the length, at birth, the length of the baby is 50 centimeter. In the first year of life, the baby gains 25 centimeter in length and becomes 75 centimeter. Next year, baby is going to gain half of what it gained in first year. So in first year, it gained 25 centimeter. Now it's going to gain 12.5 centimeter. That is 12 to 13 centimeter. And child will become 87 centimeter. Next 2 years, child is going to gain half of what it gained in second year. So in second year, it gained 12.5. Now it's going to gain 6 to 7 centimeter per year. Child is going to gain 6 to 7 centimeter per year. So at 3 years, he'll become 93 centimeter. At 4 years, he'll become 99 to 100 centimeter. So at 4 years, child finally becomes 100 centimeter. So at 4 years, finally, child is double of birth length. After this, child is going to gain height at 6 centimeter per year till the growth spurt. Till the growth spurt occurs. So finally at 12 years, child will become what? 6 into 8, another 8 years, 48. 148, that is around 150 centimeter at 12 years. Child will become 150 centimeter at 12 years. That is the tripling of birth length. There will be tripling of birth length at 12 years and doubling of birth length at 4 years. Doubling of birth length at 4 years, tripling of birth length at 12 years. Alright. And a little bit about growth curves. We all know these growth curves. This growth curve is of which tissue? 90% of growth has already occurred by 2 years. This is your brain. This is your brain. Maximum growth occurs in the first 2 years of life. Next tissue initially grows very fast, then a plateau, and then during growth spurt, it's again going to grow very fast. This is your skeletal or somatic tissue. This is your skeletal or somatic tissue. This is your skeletal or somatic tissue. This is which tissue? No growth till puberty. And when finally puberty starts, there is maximum growth. This is gonads. This is your gonads. So I told you, right, we discussed this question right now, that during puberty, you're going to have your gonadal growth, and during puberty, you'll have your skeletal growth as well, or somatic tissue growth as well. So gonadal growth corresponds with skeletal growth also, because during puberty, you will have gonadal growth. During puberty, you will also have growth spurt, resulting in skeletal growth. And this tissue is what? This is your lymphoid tissue, where the maximum growth is between 4 years and 8 years. Where the maximum growth is between 4 and 8 years. Where the maximum growth is between 4 and 8 years. Some new questions related to this. Tell me the answer. Tell me the answer to this question. A child is born with a birth weight of 3 kgs. Now the child is able to make a tower of 6 cubes. He's also able to say simple 2-word sentences. What would be the approximate weight of the child? Tell me the answer. Tell me the answer. This is how a new question can be framed. So this is a new MCQ which can be framed, and they can ask you a simple question like this. They can ask you a simple question like this. Child was born with a birth weight of what? Child was born with a birth weight of 3 kgs. Now he's able to make a tower of 6 cubes and able to say simple 2-word sentences. What will be his weight right now? Excellent. Harsh, Ranjan, Monica, Irfan, Videsh, excellent. See, his birth weight is what? So it requires 2-step thinking. His birth weight is 3 kgs. Now I'm saying he's able to say 2-word sentences. Simple 2-word sentences. Let's go back. When does 2-word sentences come? Let's see. 2-word sentences come at 2 years. 2-word sentences come at 2-word sentences come at 2 years. Tower of 6 cubes. 2 into 3, 6 cubes. So this is, now the child is 2 years. Now the child is 2 years. So this birth weight, at 1 year it becomes 3x, and at 2 years it becomes 4 times the birth weight. So 4 into 3, 12 kg. The answer is going to be 12 kg. That's how they can ask you new questions. 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 Now we come to the next topic. That is your malnutrition and Kwashiorkor and marasmus. These are the 2 things that we'll discuss right now. Then we'll come to the questions again. Now, malnutrition can be of 2 types. It can be of 2 types, acute and chronic. For acute nutrition, we use what? We use weight for length. For acute malnutrition, we use what? We use weight. We use what? Weight for length. Now, if this weight for length is less than -2 standard deviation, we call it as moderate acute malnutrition. We call it as moderate acute malnutrition. And if this weight for length is even lower, it is less than -3 standard deviation, we call it as severe acute malnutrition. We call it as severe acute malnutrition. There is no such thing as mild acute malnutrition. Between +2 and -2 is normal. Between +2 to -2 is normal. If it is less than -2, it is moderate acute malnutrition. If it is further lower than -2, it is severe acute malnutrition. Acute malnutrition, this acute malnutrition is also known as wasting. It is also known as wasting. So you can call it as moderate acute malnutrition, or you can also call it as moderate wasting. You can call it as severe acute malnutrition, or you can also call it as severe wasting. For chronic malnutrition, we use what? We use height for age. We use what? Height for age. Now, this height for age, just one second. Now, this height for age, if it is less than -2 standard deviation, we will call it as moderate chronic malnutrition. We'll call it as what? Moderate chronic malnutrition. If it is less than -3 standard deviation, we'll call it as severe chronic malnutrition. Exactly the same. And chronic malnutrition is also known as stunting. Chronic malnutrition is also known as stunting. So you can call it as moderate stunting, or you can call it as severe stunting also. Exactly the same. All right. Now a little bit more about the severe acute malnutrition. Now severe acute malnutrition, the definition of severe acute malnutrition, one definition we already discussed. Any one of the following. First, if the weight for length is less than -3 standard deviation. We already discussed this, right? If the weight for length is less than -3 standard deviation, it is severe acute malnutrition. Or if the mid upper arm circumference is less than 11.5 centimeter. But remember, this mid upper arm circumference criteria is only used from 6 months to 5 years. It is not used in children less than 6 months. Or there is bipedal nutritional edema, or there is visible severe wasting. If you have any one out of the 4, you will call it as what? You will call it as SAM. You will call it as severe acute malnutrition. For this mid upper arm circumference, we use this. This is what is referred to as, this is a Shakir stape. And Shakir stape has 3 zones. The first zone is more than 12.5 centimeter, which is green in color. Then between 11.5 and 12.5, you have a borderline zone. This is normal. Between 11.5 to 12.5 is borderline, which is yellow in color. And if it is less than 11.5 centimeter, then it becomes what? It becomes SAM, and hence red in color. So less than 11.5 is red in color, which is nothing but your SAM, So this is the definition of severe acute malnutrition. Now the severe acute malnutrition can be of 2 types. Uncomplicated SAM or complicated SAM. It can be of 2 types, complicated and uncomplicated SAM. In uncomplicated SAM, there will be no edema, appetite will be good, there will be no complications, and you can manage it at home. Complicated SAM will have complications. The name itself is saying complicated SAM means complications. There will be edema. You can have edema as a complication. Appetite is going to be poor. And this requires hospital-based management. Now, what are the complications of SAM? You can remember the complications of SAM by the mnemonic shielded. You can remember the complications of SAM by the mnemonic shielded. This is sugar. There can be hypoglycemia, hypothermia, infection, electrolyte imbalance. Which electrolyte imbalance is there? There is usually hypokalemia and hypomagnesemia. Electrolyte imbalance, dehydration, and deficiency. Micronutrient deficiency. For dehydration in SAM, always remember, for dehydration in SAM, if this dehydration is without shock, if this dehydration is without shock, we'll use what is called as risomol. We use what is called as risomol, that is rehydration solution for malnourished. We use what is called as risomol. If there is shock, you have to use IV fluids. First thing is you have to use IV fluid. Which IV fluid? IV fluid should contain dextrose because the child is already having hypoglycemia. That's why the fluid should always contain dextrose. It should always contain sugar. So we use ringer lactate with 5% dextrose. We use ringer lactate with 5% dextrose. Infection in SAM are usually by gram-negative organisms. They are usually by gram-negative organisms. These are the important complications of SAM. And the most severe forms of SAM are your Kwashiorkor and marasmus. The most severe form of SAM are your Kwashiorkor and marasmus. Now discuss this in class, that in Kwashiorkor, there is visceral protein loss. There is what? There is visceral protein loss. What is visceral protein? Visceral protein is your albumin, neurotransmitters, enzymes. There is albumin, neurotransmitters, enzymes which are lost. While in marasmus, there is somatic protein loss. There is somatic protein, that is your muscle protein loss. There is muscle protein loss. Now, obviously, if your neurotransmitters are not there in Kwashiorkor, what will happen to consciousness? Child will be dull and lethargic. In marasmus, neurotransmitters are still there. So, child will be irritable. Consciousness will be either normal or child will be irritable. What will happen to muscle in Kwashiorkor? Nothing will happen to muscle in Kwashiorkor. But in marasmus, there will be severe muscle wasting. Feeding. If the child is dull and lethargic, what's going to happen to feeding? Poor feeding. There is going to be poor feeding in Kwashiorkor. While in marasmus, neurotransmitters are present. Because neurotransmitters are there in marasmus, child will still feed. So good appetite. So there will be good appetite. Coming to fatty liver. Fatty liver is characteristic of Kwashiorkor. See, when you lose visceral proteins, you'll also lose lipoproteins. If you lose lipoprotein, what's going to happen? All the fatty acids and all the fat will stay inside the liver. It will not get transported to the other parts of the body because there is no lipoprotein in Kwashiorkor. That's why fatty liver is there in Kwashiorkor. It is not there in marasmus. Skin and hair changes. Very severe. Very severe is what? Kwashiorkor is more severe. So skin and hair changes are present in. What are the skin and hair changes? These include your flax sign. What are the hair changes? There is flax sign. This is there in Kwashiorkor. This is not there in marasmus. Edema. If you lose albumin, if there is decrease in albumin, this will lead to edema in Kwashiorkor, which is not the case as far as marasmus is concerned. So this is how it looks like. This is how Kwashiorkor is going to look like. Because there is edema, there is going to be bulging abdomen and ascites. Because there is edema, face will become edematous. It will become moon face. While marasmus will look like this. All the muscle will be lost here. You will have simian facies. and you'll have muscle wasting. You'll have muscle wasting. You'll have muscle wasting. With this knowledge, let's see the questions now. Let's see the questions now. Let's see the questions now. Let's see the first question. A 10-year-old child has presented with recurrent infection. He has presented with recurrent infection. He has low height for age. He has low height for age, which is less than -2 standard deviation, which is less than -2 standard deviation. What is the appropriate term? So height for age is used for what? Height for age is used for chronic malnutrition. It is used for chronic malnutrition. What is the other term for chronic malnutrition? Stunting. It is stunting. So the correct answer is going to be A, stunting. See, wasting is weight for length. When the weight for length is less than -2, acute malnutrition. Malnutrition can also be the answer, but the better answer is going to be stunting. Stunting is going to be the better answer. So this is incorrect. This is Kwashiorkor. They haven't given you loss of visceral protein. They haven't given you loss of albumin. So Kwashiorkor is not going to be the answer. This is stunting. This is stunting. Let's see the next question. What is the criteria for mid-upper arm circumference in Shakir's tape for severe acute malnutrition? What is the answer? Very simple question. What is the answer? What's going to be the answer here? Tell me what's going to be the answer here. What's going to be the answer here? Mangalam is right. Exactly. It's going to be less than 11.5 centimeter. Less than 11.5 centimeter is SAM. 11.5 to 12.5 is borderline. It is borderline, and more than 12.5 is normal. More than 12.5 is normal. Exactly. Let's see the next question. A young child is brought to the OPD with a swollen belly and dull face. See, swollen belly is what? Ascites. Dull face, lethargy. Child is found to have low serum protein and low albumin. What is the diagnosis? Tell me what is the diagnosis? Very important. There is a loss of, they are directly telling you there is a loss of visceral protein. And loss of visceral protein is seen where? Tell me where is loss of visceral protein? Exactly. This is going to be Kwashiorkor. This is going to be Kwashiorkor. Let's see this question. What is an accurate statement about the condition depicted in the image as presented by a child? What is this child? Can you see this child? What is this child? This is a Kwashiorkor child. Right? This is a Kwashiorkor child. If we look at the image, this looks similar to this. This is how the child looks like. Right? This is how the child is looking like. So this is Kwashiorkor. Why does Kwashiorkor occur? Kwashiorkor occurs because of protein malnutrition. There is loss of visceral protein. The answer is going to be Kwashiorkor due to protein malnutrition. Kwashiorkor due to protein malnutrition. Now, next question is, a child is malnourished. He has no subcutaneous fat. Skin was wrinkled and muscle. There is muscle loss. Muscle loss. M for muscle, M for marasmus. And marasmus has what loss? Marasmus has calorie deficiency. Marasmus has calorie deficiency. So the answer is going to be deficiency of energy, that is calories. Correct answer is going to be option D. Correct answer is going to be option D. Correct answer is going to be option D. Now, tell me the answer to this question. A 15-month mother has a son and his length for age is less than -2 standard deviation. A 15-month has length that is less than -2 standard deviation. What is the most probable condition? Tell me the answer. Tell me the answer to this question. Exactly. Very good. Tell me the answer to this question. What's going to be the answer? So when length for age is gone, this is what? This is stunting. This is going to be stunting. Which kind of stunting? Moderate stunting. If it was less than -3, it would have been severe stunting. So correct answer is going to be option D, that is moderate stunting. Moderate stunting. That is moderate stunting. Now, tell me the answer. What's going to be the answer? What is the most specific clinical feature for Kwashiorkor? So Kwashiorkor, what is the most specific feature? What is the most specific feature? It is loss of visceral protein. Like, that is the main feature of Kwashiorkor. Like albumin. Like albumin. That is the most specific feature. That is the most specific feature for diagnosis for Kwashiorkor. Answer is going to be low serum albumin. Answer is going to be low serum albumin. Answer is going to be low serum albumin. See, they're asking most specific. Edema can occur in other conditions. Fatty liver can also occur in other conditions. Answer here is going to be low serum albumin. Answer is going to be low serum albumin. It's going to be low serum albumin. Edema can occur in other conditions. Easily pluckable where can occur in alopecia. Fatty liver can occur in adults also. Adults also have fatty liver. Low serum albumin is most characteristic of what? Kwashiorkor. Most characteristic of Kwashiorkor. All right. With this, next let's come to some new question. Let me ask. Tell me the answer to this question. This is a new question that I've made for you. This is a new question I've made for you. Tell me the answer to this question. Tell me the answer to this question. Exactly. Not D. Krishna Karishma, it is not going to be D. C. Weight for length is minus 3.2. Weight for length is less than minus 3 standard deviation. It is SAM. It automatically becomes SAM. It is not moderate. Moderate would have been minus, if it was let's say minus 2.2. If it was let's say minus 2.2, that would have been moderate. Minus 3 means severe acute malnutrition. Now, I'm telling you, he's able to take food. There is no hypoglycemia, dehydration means there is no complication. Means there is no complication. So the answer is going to be uncomplicated SAM or no complication SAM. This is going to be option C. It's uncomplicated SAM. Weight for length is less than minus 3. There is no hypoglycemia, no complication. So uncomplicated SAM. That's how you have to come to this answer. This is not moderate acute malnutrition. There is no complications. How can it be complicated SAM? And it is not height for age which is low. It is weight for length which is low. So chronic malnutrition can also not be the answer. Answer is uncomplicated SAM. Answer is uncomplicated SAM. No medical complication, hence uncomplicated SAM. Right? Good appetite. Exactly. There is good appetite. He's able to take food. So obviously good appetite. Exactly. Exactly. All right. Now let's come to the discussion of dehydration. Now let's come to the discussion of dehydration. Let's come to the discussion of dehydration. According to MNCI, when a child has come to you with dehydration, you will classify it into 3 categories. No dehydration, some dehydration, and severe dehydration. No dehydration, some dehydration, and severe dehydration. How will you classify into this no, some, and severe? Depending upon the clinical features. So, depending upon the clinical features, you will classify the child into no, some, and severe dehydration. What clinical features you are going to use? You are going to use 4 clinical features. These 4 clinical features are your consciousness, thirst, skin pinch, and eyes. These are the 4 clinical features on the basis of which you will classify the child into no, some, and severe dehydration. Into no, some, and severe dehydration. You will say the child has no dehydration if the consciousness is normal. In some dehydration, because the child has lost some water, child will become irritable because he wants water. Child will be irritable. In severe dehydration, child has lost so much water, child will become dull and lethargic. Child will become lethargic. Thirst will be normal in no dehydration. In some dehydration, child has lost some water, so he wants to take a lot of water. So there is going to be increased thirst, or child will drink eagerly. In severe dehydration, because the child is lethargic, so child will not be able, because he is lethargic, how will he be able to drink water? He is unable to drink water. Skin pinch will be normal in no dehydration. In some dehydration, skin pinch will be delayed. That is, goes back slowly. In severe dehydration, it will go back very slowly or very delayed. Very slowly or very delayed. Eyes will be normal in no dehydration. In some dehydration, eyes will be sunken. Eyes will be very sunken in case of severe dehydration. They will be very sunken in case of severe dehydration. Now, how will you manage this severe dehydration? How will you manage dehydration according to IMNCI? So, IMNCI divides management of dehydration into 3 plans. Plan A, Plan B, and Plan C. There are 3 plans. Plan A is used for no dehydration. And it is coded as green. It is coded as green in the IMNCI chart. Plan A is no dehydration. In no dehydration, if there is no dehydration, what are you going to do? You will just replace ongoing losses. So child has come to you with dehydration, he has come to you with, let's say, diarrhea, because of which he is going to dehydration. You will replace the diarrheal losses. Anytime he has an episode of loose stool, you will replace that. You will just replace ongoing fluidia diarrheal losses. How much? You will give 10 ml per kg of ORS with each loose stool. So anytime he has a loose stool, you will give 10 ml per kg of ORS. So let's say there is a 10 kg child, anytime he has a loose stool, you will give 100 ml of ORS anytime he has a loose stool. Now a little bit about this ORS and how is it different from Risomol. So ORS has sodium, it has glucose, it has potassium, it has chloride, and it has citrate. Sodium in ORS is 75 millimole per liter. Glucose is also 75. Potassium is 20. Chloride is 65. Citrate is 10. So that the total is 245. Risomol is the fluid which we use in malnourishment, in malnutrition. See, in malnutrition, what was happening? In malnutrition, hypoglycemia was there. Remember, in malnutrition, hypoglycemia was there. And hypokalemia also was there. So that is the reason why in Risomol, because there is hypoglycemia, glucose is going to be higher. Because there is hypokalemia also, potassium is also going to be higher. So Risomol, sodium is actually 45. Glucose is actually 125. Potassium is 40. Chloride is 75, citrate is 7, and magnesium is 3. So this is how Risomol is different from normal ORS. This is for no malnutrition. And this is if the child is having SAM. Or malnutrition. Okay, if the child is having SAM or malnutrition. Alright. So Risomol has, if you look closely, this is very important. This has been asked multiple times in FMG. The glucose is higher. As compared to normal ORS. Normal ORS is 75. In Risomol, there is 125. Very important. Now coming to Plan B. Plan B is for some dehydration, which is coded yellow. Which is coded what? Which is coded yellow. In some dehydration, what we are going to do? We are going to do replacement of whatever dehydration has occurred. And we are going to give what? We are going to give ORS again. How much? This time we are going to give 75 ml per kg over 4 hours. This ORS can be given orally or NG in Plan B. Alright. Now coming to Plan C. See, plan C is used for severe dehydration, which is basically red, which is coded red. In severe dehydration, child was dull and lethargic. You can't give ORS. You cannot give ORS. You have to give IV fluids because the child is dull and lethargic. He cannot drink water. He cannot drink ORS. So you cannot give ORS. You have to use IV fluids. Which IV fluids? You will use RL with 5% dextrose, followed by RL, followed by NS. The preferred is always RL with 5% dextrose when you are using IV fluids. What's going to be the amount? Amount is going to be 100 ml per kg. This 100 ml per kg will be given in two different parts. A first part of 30 ml per kg and the remaining part of 70 ml per kg. If the child is less than 1 year, the 30 ml per kg is given over 1 hour. The remaining 70 ml per kg is given over 5 hours, so that the total 100 ml per kg is given over 6 hours. If the child is more than 1 year, this 30 ml per kg is given over half hour. The remaining 70 ml per kg is given over 2.5 hours, so that the entire 100 ml per kg is given over 3 hours. This is for plan C, that is your severe dehydration. Alright, let's summarize it. In plan A, what are you using? ORS. How much? You are giving 10 ml per kg with each loose stool. No time point. Anytime you have a loose stool, you will give it. In plan B, again you are using ORS. What is the amount? This time it is 75 ml per kg. Given over 4 hours. In plan C, you are using IV fluids. That is RL with 5% dextrose. Given how much? 100 ml per kg you are giving. Over 3 hours if the child is more than 1 year, and over 6 hours if the child is less than 1 year. So this is your plan A, plan B, plan C. Plan A is for no dehydration, plan B is for some dehydration, and plan C is for severe dehydration. Now let's see the questions. Let's see the questions once. A 10-year-old child has brought to the OPD with complaints of poor appetite and failure to thrive. Okay, so failure to thrive, poor appetite. Upon further examination, loss of skin turgor, dry mucus is noticed. What is the glucose content of the rehydration solution used to treat this condition? So basically, first they are telling you child is having what? Child is having malnourishment. Child is malnourished. That's why they are saying failure to thrive. That's why they are saying poor appetite. So child is malnourished. In malnourished, I told you what you are going to use? You are going to use Risomol. And what is the glucose content of Risomol? Tell me what is going to be the answer here. Why 100 millimole? We just discussed. What are you saying? That was 100 ml per kg. See the question carefully. Don't make these silly mistakes. Question is asking what is the glucose content. Question is not asking how much 100 ml per kg or 75 ml per kg. Question is asking glucose content. We just discussed this. For malnourishment, we use Risomol. Risomol has glucose of 125. So answer is going to be B. 125. Don't make such silly mistakes. These are the common silly mistakes you are going to do. Nobody is asking you 7500 ml per kg. They are asking you the glucose concentration. Read the question carefully. Answer is going to be B. 125 millimole. Now let's see this question. A 2-year-old male child was brought to the pediatric department with loose stools. She's having severe dehydration. So there is severe dehydration. Severe dehydration. Child is 2-year-old. And that is more than 1 year. What is the volume of fluid to be given in the 3 hours if the weight is 10 kg? So remember, in severe dehydration, if more than 1 year, you give how much? You give 100 ml per kg over 3 hours. If it was less than 1 year, you would have given what? You are given 100 ml per kg over 6 hours. But now child is more than 1 year. You will give 100 ml per kg over 3 hours. So it is 100 into weight, what is 10? That is going to be 1000. That's how you have to solve the question. Answer is going to be option B, 1000 ml. Answer is going to be option B, that is 1000 ml. More than 1 year. 100 ml per kg over 3 hours. Weight is 10 kg. So 100 into 10, 1000 ml. Answer is going to be option B. Let's see the next question. A child with diarrhea was eager to drink and the skin pinch went back slowly. Child was eager to drink. Eager to drink means increased thirst. Skin pinch went back slowly. This is pointing towards what? This is pointing towards some dehydration. In severe dehydration, it would have gone back very slowly. In severe dehydration, child would be unable to drink. So this is some dehydration. And some dehydration is what? Yellow. Some dehydration is yellow. So answer is going to be yellow. Let's see this question. A child presented to the clinic with complaints of malnutrition and severe dehydration. What is the IV fluid? So remember, I discussed this in malnutrition. What is the IV fluid we give? What is the IV fluid if you have dehydration? What's going to be the IV fluid? What's going to be the IV fluid? What's going to be the IV fluid? Exactly, it's going to be RL with 5% dextrose. So anytime you are going to use IV fluids in dehydration, it's going to be RL and 5% dextrose. Now let's see this question. A 3-year-old child has come with OPD with severe diarrhea, deeply sunken, very sunken eyes, severely dehydrated. They're already telling you there is severe dehydration. What will you use in severe dehydration? What will you use in severe dehydration? What will you use in severe dehydration? What's going to be the answer here? What's going to be the answer here? In severe dehydration. Exactly. Now it's going to be B again. So anytime you have severe dehydration, it's going to be RL with 5% dextrose. It's going to be RL with 5%. So answer is going to be RL with 5% dextrose. Answer is going to be RL with 5% dextrose. Again, simple. Again, the same question. See how many, all these are FMG question which they have asked multiple times. So see how much they love to ask RL with 5% dextrose. What is the fluid of choice for shock in a child with SAM? Now what's going to be the answer? Again, it's going to be RL with 5% dextrose. So see how many times they have asked RL with 5% dextrose. Multiple different scenarios, but the answer stays the same. RL with 5% dextrose. RL with 5% dextrose. Again, it's going to be RL with 5%. Again, it's going to be RL with 5% dextrose. Or again, it's going to be RL with 5% dextrose. Now, tell me what is going to be the answer to this question. Tell me what is going to be the answer to this question. This is a tricky question. This is actually a tricky question. This is actually a tricky question. Tell me what's going to be the answer to this question. A 7-month-old, 18 episodes of loose stool, 4 episodes of vomiting, irritable but drinking water. Irritable but drinking water. Tell me what's going to be the answer here. He's irritable but drinking water. What's going to be the answer? Array, think logically. Think logically. Irritable, drinking water. If someone is drinking water, why will you use IV fluids? Why will you use IV fluid? This automatically says no IV fluids. If someone is drinking water, why will you ever use IV fluids? And irritable means what? Irritable means some dehydration. Irritable means some dehydration. And in some dehydration, what were you doing? In some dehydration, what were you doing? In some dehydration, what was the fluid? ORS. You are giving ORS only in some dehydration. You will never use IV fluids in some dehydration. You will never use IV fluids in some dehydration. So what's going to be the answer here? He's irritable. Some dehydration. Drinking water means no IV fluid. You are going to use ORS only. This is some dehydration. In some dehydration, why do you want to use IV fluids? It's going to be ORS only. It's going to be ORS only. Right? It's going to be ORS only. Exactly. It's going to be ORS only. Now, with this, we have completed the IMNCI management of dehydration. Now, let's see the IMNCI management of pneumonia. Let's see the IMNCI management of pneumonia. Now, IMNCI says pneumonia is of three types. IMNCI says pneumonia is of three types. No pneumonia, pneumonia, and severe pneumonia, or very severe disease, Okay, so we'll classify pneumonia into no pneumonia, pneumonia, or severe pneumonia, or very severe disease. So what will be the clinical features of no pneumonia? If there is no pneumonia, child will have only cough and cold and no features of pneumonia or severe pneumonia. So in case of no pneumonia, child will have only cough and cold. No features of pneumonia. Wheezing can be there. Wheezing is plus minus. How will you manage no pneumonia? Do you need antibiotic? If there is no pneumonia, why do you need antibiotic? So you will use, there is only cough cold. Vicks ki goli lo, kuch dur karo. Just soothing measures. Only. Like soothing measures. If wheezing is there, you can use salbutamol. Salbutamol is plus minus if wheezing is there. Okay. Now, as far as pneumonia is concerned, pneumonia can be of two types. Fast breathing pneumonia or chest indrawing pneumonia. Fast breathing pneumonia or chest indrawing pneumonia. Now, fast breathing pneumonia, you will say if the breathing is fast, if the respiratory rate is fast. So you'll use some cutoffs for this. So the respiratory rate cutoffs will be dependent upon the age of the child. Less than 2 months, 2 to 12 months, and more than 12 months. For a child less than 2 months, the respiratory rate cutoff is 60. For 2 to 12 months, the respiratory rate cutoff is 50. For more than 12 months, the respiratory rate cutoff is 40. So anytime the respiratory rate is more than this, you will say the child is having fast breathing pneumonia. Or if the child has chest indrawing, then automatically you will say that child is having chest indrawing pneumonia. For pneumonia now, if there is either fast breathing or chest indrawing pneumonia, now you need to give antibiotic. Which antibiotic? You will give amoxicillin for 5 days. You will give oral amox for 5 days and you'll ask the mother to follow up in 2 days to ensure that there are no danger signs. When you will say there is severe pneumonia, you will say severe pneumonia if there is stridor in an otherwise calm child. If there is stridor in an otherwise calm child, you will say there is severe pneumonia. When you will say there is very severe disease, when there are danger signs. What are the danger signs that can be there? Or if the danger signs are present, what are the danger signs? If there is high grade fever, convulsions, fall in SpO2, poor feeding or lethargy. If there are danger signs like this, high-grade fever, convulsions. Convulsions is what? Convulsions is seizures. Fall in SpO2, poor feeding, lethargy. You'll say the child is having very severe disease, or if there is stridor in an otherwise calm child, you'll say there is very severe disease or severe pneumonia. Now, in this case, you will refer. You won't manage this child in a PHC. You will refer this child after the first dose of IV antibiotic, which can be ampicillin or gentamicin. So this is the IMNCI management of pneumonia. First, classify the child into no pneumonia, pneumonia or severe pneumonia. No pneumonia, Vicks ki goli lo, khich khich dur karo. Pneumonia, amox for 5 days. Severe pneumonia, refer. You won't treat after the first dose of IV antibiotics. Now let's see the questions that they had asked. A 2-year-old child presented with fever and cough, not able to take feeds for 2 days. On examination, respiratory rate is 42 and chest and drawing is present. What is the diagnosis and treatment? Severe है, सही कह रहे हो, severe है. See this. Not able to take feeds. This is poor feeding. If there is poor feeding, you will, answer is going to be option A, severe pneumonia. Give antibiotics and refer urgently. That is going to be the answer. Why not this? Because you have to give IV antibiotic. At least the first dose you have to give. So option A is a better answer as compared to option B. Is it only pneumonia? No. He's unable to take feeds. This is poor feeding. So poor feeding means severe pneumonia. You have to give the first dose of IV antibiotics and you have to refer the child. This is going to be option A. Now let's see this question. A 1.5-year-old child, 1.5-year-old child, okay, is brought to the hospital with a history of breathlessness, fever less than 37, okay, cough and cold. Respiratory rate is 46. There is no chest reactions. There is no chest and drawing. What is the most appropriate management? What will be the answer here? So child is more than 1 year. What is the respiratory rate cutoff? The respiratory rate cutoff is 40. So this is fast breathing pneumonia. There is no high grade fever. That's why they are saying fever less than 37. There is no high grade fever. There are no other danger signs. So answer will be administer oral antibiotics, warn of danger sign and send home. Answer will be administer oral antibiotic. Which oral antibiotic? Amoxicillin. Now let's see this question. A 3-month-old child complains of fever, cough, not able to feed. What is going to be the answer again? Now what is going to be the answer? A 3-month-old child not able to feed. What's going to be the answer? Again, the answer is going to be option A. This is severe pneumonia, give antibiotics and refer immediately. This is going to be severe pneumonia, give antibiotics and refer urgently. Anytime you have poor feeding or lethargy, it is severe pneumonia. Alright, so this is how they ask questions related to pneumonia. This is how they ask questions related to pneumonia. Now tell me what is the answer to this question. Another respiratory system disorder, very important respiratory system disorder, which they have asked multiple times. Tell me the answer to this question. What's the answer to this question? A 5-year-old child A 5-year-old child has presented with recurrent respiratory tract infections, recurrent LRTI with thick sputum, very important. With what? Thick sputum. There is thick sputum. He has been suffering from steatorrhea. Steatorrhea is what? Fat in stools. This is fat in stools, which is the first differential diagnosis. Exactly. This is going to be your cystic fibrosis. The answer is going to be cystic fibrosis. Let's learn a little bit about cystic fibrosis. Cystic fibrosis is very important. What is the cause of cystic fibrosis? It is mutation in a gene called CFTR gene, which encodes for a chloride conductance channel. The most common mutation in cystic fibrosis is delta F508, which stands for deletion. Delta stands for deletion, F stands for phenylalanine. At the 508th amino acid position. And this is inherited in a autosomal recessive manner. Cystic fibrosis is also called mucoviscoidosis. It's also called mucoviscoidosis. And we'll come to why it's called as mucoviscoidosis. So there is a problem in what? In cystic fibrosis. In cystic fibrosis, there is a problem in a chloride conductance channel. This is the core of cystic fibrosis. Now, why does this chloride conductance channel problem lead to cystic fibrosis? Let's understand this. Let's understand the pathophysiology. Let's understand the pathophysiology. Let's understand the pathophysiology. Now, the function of the CFTR or chloride conductance channel is the same in airway and pancreas, and even in gut. What it does is, it will transport chloride from inside the cell into the lumen. Let's assume this is the lumen. What it will do, it will transport the chloride from inside the cell into the lumen. Now, if chloride has come into the lumen, it will attract a positive ion. It will attract what? It will attract sodium. It will attract sodium. If sodium chloride is now into the lumen, what will it attract? It will attract a lot of water. It will attract a lot of water. Now, water, when it comes into the lumen, it will make the secretions very watery. The airway secretions, the pancreas secretion, the gut secretions, they will become what? They will become watery. There will be watery secretions. There will be watery secretions. This is a normal function of CFTR. So what will happen in cystic fibrosis? What's going to happen? This won't take place, this won't take place, and of course then this won't take place because that CFTR is defective. As a result, water will not come into lumen. So these secretions will not stay watery. These secretions will no longer stay watery. They will become what? They will become very, very thick. And these thick secretions are at the core of everything that is associated with cystic fibrosis. When you have thick secretions in the airway, you will not be able to get it out, resulting in recurrent infections, recurrent LRTI. When there is thick secretions in pancreas, pancreatic enzymes won't be able to come out. There will be pancreatic insufficiency. If pancreatic enzymes are not out, lipase won't come out. If lipase is not there, fat won't be absorbed. If fat is not absorbed, there is going to be steatorrhea. If fat is not absorbed, what's going to happen? There will be deficiency of fat-soluble vitamins. A, D, E, K deficiency is going to be there. All the pancreatic enzymes, they are not able to come into the lumen. They will get activated where? They'll get activated in the pancreas itself, causing recurrent pancreatitis. Gut also will have thick secretions. If there are thick secretions in gut, what is going to happen? There is going to be constipation. If there is constipation, it will put a lot of pressure like this. Lot of pressure like this will cause the rectum to come out. Rectal prolapse. And in the newborn, if there is thick secretion, if there is thick gut secretions, meconium passage will not take place normally. It will be delayed. So everything in the case of cystic fibrosis is because of the fact that the secretions have become very, very thick, very, very viscous. That is the reason why it is also called mucoviscoidosis. The only place where the function of the CFTR is opposite is sweat glands. In sweat glands, the function is opposite. So this CFTR actually helps in chloride absorption. It helps in chloride absorption. So what will happen in cystic fibrosis? What will happen in cystic fibrosis? This chloride absorption won't take place. Chloride will stay in the lumen, and this will lead to increased sweat. This will lead to increased sweat chloride. And this is used for diagnosis. This is used for diagnosis. So what will be the clinical features of cystic fibrosis? You'll have recurrent LRTI. I told you thick secretions, recurrent LRTI. That can lead to bronchiectasis. The most common organism, remember, is staph followed by Pseudomonas. But Pseudomonas is more specific. It is more specific than staph. Then you will have pancreatic insufficiency because pancreatic enzymes are not coming out. That will lead to chronic diarrhea. Because there is absence of lipase, this absence of lipase will lead to fat malabsorption, which is called steatorrhea. In the gut, again, there is going to be thick secretions. There will be thick secretions. This will lead to what? This will lead to constipation. This can lead to constipation. That can lead to a lot of, pressure, intra-abdominal pressure. That will lead to rectal prolapse. There will also be delayed meconium passage. And there can also be something called as DIOS, distal intestinal obstruction syndrome, again because of thick secretions. And they also have one another characteristic feature, that they have congenital absence of vas deferens. Because there is no vas deferens, there will be no sperms that will come out in the semen, which is referred to as azoospermia. So they will be infertile. The diagnostic criteria. What will be the diagnostic criteria? Any one of the following. The most important diagnostic criteria will be sweat chloride. I told you that is used for the diagnosis. So when there is increased sweat chloride more than 60 milliequivalent per liter on 2 occasions, or that is the most important. If that is not there, you can test for the gene. You can test for mutations in the gene or CFTR mutations. How many mutations? At least 2 mutations. Or abnormal nasal potential difference. Any one out of these 3, you will say the child is having cystic fibrosis. So this is how they ask the questions related to cystic fibrosis. Next kind of question they could have asked was, what is the most common organism? The answer would have been staph. They could have asked most specific organism. Answer would have been Pseudomonas. These are the kind of questions they'll ask related to cystic fibrosis. Once they simply asked, what is the mechanism of inheritance? Answer was autosomal recessive. Once they asked, what is the most common mutation? Answer was delta F508. Cystic fibrosis is very, very important. Okay, so this is as far as cystic fibrosis is concerned. Now, tell me the answer to this question. Another important topic here, neural tube defects. What is the answer to this question? Tell me what is the answer to this question. Exactly. Can you see? There is no brain. So this is anencephaly. Now tell me, what is the answer to this question? Which is the best sensitive marker for neural tube defects? What is going to be the answer here? This is not spina bifida. Can you see? There is no brain. There is absolutely no brain. This is anencephaly. Now tell me, what is the best sensitive marker for neural tube defects? Look at this. Question is asking sensitive. Not specific. Question is asking sensitive. sensitive, the answer is going to be alpha fetoprotein. This is the most specific marker. If they ask you the most specific marker, acetyl. If they ask you the most sensitive marker, alpha fetoprotein. Alpha fetoprotein. So neural tube defects can be of two types. Caudal means at the lower part, and cranial. Neural tube defects can be of caudal, two types, caudal and cranial. Caudal neural tube defects includes your spina bifida. It includes your spina bifida. Spina bifida itself is of two types, spina bifida occulta and spina bifida cystica. Spina bifida occulta and spina bifida cystica. It will occur caudally, it will not occur cranially. By definition, spina bifida is what? Caudal. By definition, spina bifida is caudal. There is no such thing as cervical spina bifida. There is no such thing as cervical spina bifida. You are seeing the defect in the cranial portion. So it cannot be spina bifida. It cannot be spina bifida. By definition, caudal neural tube defect is spina bifida, which can be of two types, occulta and cystica. Let's learn a little bit about the spina bifida. So spina bifida occulta. In spina bifida occulta, what happens? Is there any defect which is visible? No visible defect. There is a defect only in spine, in the vertebral spine, alright, which is covered with skin. And that is the reason, because it is covered with skin, there is no visible defect. Because there is no visible defect, that's why it's called spina bifida occulta. That's why it's called spina bifida occulta. Okay, no visible defects. Sometimes over that there might be a tuft of hair. Sometimes a tuft of hair might be present, but most of the time there is no visible defect. That's why it's called spina bifida occulta. Now these two together, meningocele and myelomeningocele, they are called spina bifida cystica. They are called spina bifida cystica. First is meningocele. In meningocele, see what happens? The meningeal covering is covering out. Only meninges come out. Only the meningeal covering is coming out. In myelomeningocele, you have the spinal cord plus meninges. You can see the spinal cord also coming out. Plus meninges also come out. So in meningoceles, there will be no deficits, no neural deficits, while these neural deficits will be present in myelomeningocele. So this is your caudal neural tube defects. This is your caudal neural tube defects. Now we come to cranial neural tube defects. Cranial neural tube defects, you should remember two things. In cranial neural tube defects, this is one. This is what? This is anencephaly. This is anencephaly. No cranium, no brain. And this is what? This is inencephaly. In encephaly, what is happening? There is defect of occiput. Occiput is not there. There is no neck also. So there is a defect of occiput and cervical spine. And because of this, their head is retroflexed and they are looking like that. This is also called star-gazing posture. So you will see this star-gazing posture. You will see this star-gazing posture in encephaly. You will see this in encephaly. You will see this in encephaly. So as far as cranial neural tube defects is concerned, there is anencephaly and inencephaly. Why does anencephaly occur? It occurs because of complete failure of anterior neuropore closure in 4th week. In which week? 4th week. This 4th week also has been asked once. Why does anencephaly occur? Because of a complete failure of anterior neuropore closure in the 4th week of life. Which week of life? In the 4th week of life. This 4th week also is a previous year question. This 4th week is also a simple one-liner previous year question. This has also been asked once. This also has been asked once. Alright. Now, coming to the diagnosis, coming to the antenatal detection, you can use an ultrasound or you can use serum markers. In serum markers, I already told you, alpha fetoprotein is most sensitive and acetylcholinesterase is most specific. Ultrasound, which is the earliest which can be detected? The earliest neural tube defect which can be detected is anencephaly, which can be detected as early as 10-week period of gestation. What is the sign that you see? What is the sign that you see? What is the sign that you see? That's a radio question. There is a radio question. This is your homework. This is your homework. What is the sign that you see in anencephaly on ultrasound? This is your homework. Okay? Revise radio also. Go through the Rajat sir's video one shot. You will know the answer. You will know the answer. Tell me the answer. Exactly. Very good. Lemon and banana. Lemon and banana. Excellent. See, that's how you integrate. That's how you integrate also. That's how you integrate also. That's how you integrate also. All right. So this is your neural tube defects. This is your neural tube defects. This is your neural tube defects. Now we come to breast milk. 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 Tell me what is the answer to this question. Which vitamin is deficient in breast milk? Tell me the answer to this question. Tell me the answer to this question. Excellent. And the option that you are seeing, this also is deficient. Right? So breast milk is deficient only in two things. It is deficient only in two things. Vitamin K and vitamin D. It's deficient only in two things. Vitamin K and vitamin D. Because vitamin K is deficient, that's why at birth you give injection vitamin K intramuscularly. That's why at birth you give injection vitamin K intramuscularly. And for vitamin D, you give oral vitamin D 400 international units for 1 year. You give oral vitamin D 400 international units for 1 year from birth till 1 year of age. These are the only two things which are deficient in breast milk. Vitamin K and vitamin D. Vitamin K and vitamin D. Vitamin K and vitamin D. Alright, always remember that. Now tell me the answer to this question. A prima gravida delivers a baby via normal delivery. After how many hours should she initiate breastfeeding? After how many hours she should initiate breastfeeding? Tell me the answer to this question. Exactly. See, the answer actually is ASAP. It is actually not, it's actually a kind of counterintuitive question. Answer is always going to be ASAP. As soon as possible. If she's able to initiate in 5 minutes, given 5 minutes. If she's able to 30 minutes, given 30 minutes. As soon as possible. Ideally within 1 hour. Ideally, she should start breastfeeding within 1 hour. Ideally, she should start breastfeeding within 1 hour. Ideally, she should start breastfeeding within 1 hour. Okay. Now tell me, which of the following is an absolute contraindication for breastfeeding? Look at the word very carefully. Which of the following is an absolute contraindication for breastfeeding? Which of the following is an absolute contraindication for breastfeeding? Even if she's on labor table, you should give as soon as possible. Multigravida also, she should give as soon as possible. There is no difference in primary and multi. That's why they wanted to confuse you. This can be multigravida also. This can be multigravida also. The answer will stay the same within 1 hour. Answer is galactosemia. Remember, there are only two absolute contraindications to breastfeeding. One is galactosemia. Other is on chemo. If the mother is on chemo or radiotherapy. Alright. So a little bit about breastfeeding. a little bit about breastfeeding. So what is the lactose in breast milk? It is 7 gram per deciliter. How much in cow's milk? 4 gram per deciliter. Fats, they are actually same in both. Both have 3 to 4 gram per deciliter of fats. Breast milk and cow milk both have similar amount of fats. But breast milk is better. Why? Because this DHA in arachidonic acid is actually 20x. And this helps in brain growth. This helps in brain growth. Coming to calories, more calories in breast milk. 67 kilocalorie. While there is only 62 kilocalorie in cow's milk. Protein absolute amount is less in breast milk. It is only 1.1 while it is 3.5 in cow's milk. But the protein quality is better. The protein quality is better in breast milk. Why? Why is the protein quality better? Because maximum protein is actually whey protein. It is 60:40. Or sometimes it is even written as 70:30. Whey to casein ratio is 60:40, sometimes given as 70:30. More important, there is more amount of whey. More important, it's more amount of whey. While in case of cow's milk, it is 20:80. It is 20. Maximum amount of protein is what? It is casein. And what is the problem with casein? Casein will coagulate. Casein will coagulate, so you will not be able to absorb. The absorbable protein is more in breast milk. That is, the whey protein is more in breast milk. Calcium to phosphate ratio in breast milk is 2:1, while it is 1.5:1 in cow's milk. And this higher amount of calcium helps in better absorption. Now coming to contraindications, always remember there are only two absolute contraindications of breast milk. One is your galactosemia. Other is active chemotherapy in mother. Active chemotherapy or radiotherapy. Remember, active HIV, active TB or active herpes, these are relative contraindications. They are not absolute contraindication. And things like lactational mastitis, breast milk jaundice, maternal smoking, they are not even a contraindication. You should continue breastfeeding. So this is related to the contraindications of breastfeeding. This is related to contraindications of breastfeeding. Now I come to the difference between nephritic and nephrotic syndrome in children. So in case of children, you can have either nephritic or nephrotic syndrome. Some important differences between. Tell me, who will have hematuria, nephritic or nephrotic? Who will have hematuria? Who will have hematuria? Tell me. Who will have hematuria? Who will have hematuria? Nephritic, exactly. So hematuria is there in nephritic syndrome. Nephritic syndrome is nothing but glomerulonephritis. It will not occur in nephrotic syndrome. Proteinuria, nephritic will have proteinuria. 1+, 2+ proteinuria. Nephrotic will have nephrotic range proteinuria. That is 3+, 4+. And this will lead to decrease in albumin less than 3 and severe edema. This will happen in nephrotic syndrome. Hypertension will be there in nephritic syndrome. It will not be there in nephrotic syndrome. RBC cast will be there in nephritic syndrome. And dysmorphic RBCs will be there in nephritic syndrome. While this will not be there in nephrotic syndrome. The most common cause of glomerulonephritis or nephritic syndrome in children is PSGN, that is post-streptococcal glomerulonephritis. While the most common cause of nephrotic syndrome is minimal change disease. It is minimal change disease. It is minimal change disease. It is minimal change disease. Okay. Now coming to PSD and post streptococcal glomerulonephritis. What is the organism? It is group A beta hemolytic streptococcus. And what is the mechanism? What is the mechanism? It is immune complex deposition. The second most common glomerulonephritis in children is IgA nephropathy. IgA nephropathy. Then we come to nephrotic syndrome. In nephrotic syndrome, what is the most common? It is minimal change disease. In minimal change disease, on light microscopy, everything is normal. That's why it's called minimal change disease. On light microscopy, you will not see anything. But on electron microscopy, you will see effacement of. Effacement means destruction of food process. You will see effacement or destruction of food process. And the drug of choice for nephrotic syndrome in children is prednisolone. It is what? Prednisolone. So this is the important difference between nephritic and nephrotic. Nephritic will present with hematuria, RBC cast, dysmorphic RBCs. Nephrotic will present with what? It will present with proteinuria, severe proteinuria plus edema. It will present with severe proteinuria plus significant edema. Now let's see the question. Let's see the questions which were asked in FMG. What is the most likely diagnosis for a 9-year-old child who presents with hematuria, hypertension, and a recent history of throat infection, facial puffiness, and urine examination showing albumin positivity? So there is hematuria. There is some proteinuria. 1 plus 2 plus can occur. Hypertension. What's going to be the answer? What's going to be the answer? What is the throat infection caused by which? What's going to be the answer here? It's going to be, tell me what's going to be the answer here. Exactly, it's going to be C. Gas. Remember, gas causes PSD. And what is gas? Group A. Remember, you can remember it like that. Group A beta hemolytic. It is group A beta hemolytic. It is group A beta hemolytic. So answer is going to be option C. Excellent. Now let's see this question. Following urine microscopy, child is found to have hematuria and RBC casts. What is the probable cause? What is the most probable cause? What is the most probable cause? Tell me what is going to be the answer. What is the most common cause of glomerulonephritis in children? What is the most common cause of glomerulonephritis in children? Again, it is going to be post-streptococcal glomerulonephritis. Again, it is going to be post-streptococcal glomerulonephritis. FSGS causes nephrotic syndrome. It is the second most common cause of nephrotic syndrome. This also causes nephrotic syndrome. This is the most common cause. This is the most common cause. Alright. This causes your glomerulonephritis. That is your RBC cast. That is your RBC casts. That is your RBC cast. Now tell me what is going to be the answer here. Edema. Generalized edema. Light microscopy was normal. Urine showed massive. Massive means 3 plus 4 plus proteinuria. What is the diagnosis? Light microscopy is normal. What is the diagnosis? What is the diagnosis? Now what's going to be the diagnosis? Now what's going to be the diagnosis? For this question, what's going to be the diagnosis? Now it's going to be minimal change disease. Because it's minimal change disease, that's why light microscopy is normal and electron microscopy is showing effacement of food process. It's showing what? Effacement of food process. Alright, now again question. Next question. Let's see the next question. A 10-year-old child with 4 plus proteinuria, generalized edema. So you know what? It is nephrotic syndrome. This is nephrotic syndrome. Which drug would you prefer initially? What is the drug of choice? What is the drug of choice? What is the drug of choice? What is the drug of choice for nephrotic syndrome? What is the drug of choice? Tell me, what's the drug of choice? Exactly. Now the answer is going to be prednisolone. So this is how they ask questions related to nephritic and nephrotic syndrome. So this is how they are going to ask questions related to nephritic and nephrotic syndrome. Now, I'm going to ask you tell you one very important genetic disorder which they love in FMG. In fact, they don't love it in fact, they don't like it as far as your NEET PG is concerned. It's your Noonan syndrome. It's your Noonan syndrome, and the difference of Noonan syndrome compared to Turner syndrome. So you have to understand that both Noonan and Turner have same phenotype. Both Noonan and Turner have same phenotype. What do I mean by same phenotype? Both will have short stature. Both will have webbed neck. Both will have widely spaced nipple. These things are there in both Turner and Noonan syndrome. The problem and the difference is in genotype. Turner syndrome occurs because of XO, monosomy X. And that's why it is seen only in girls. While Noonan syndrome occurs because of PTPN11 mutation, which is autosomal dominant in nature. Because it is autosomal dominant in nature, Noonan is seen both in girls and in boys. It's seen both in girls and boys. In Turner syndrome, most common cardiac defect is bicuspid aortic valve. That is the left side of the heart. Aorta arises from the left ventricle. In Noonan syndrome, the most common cardiac defect is pulmonary stenosis. That is the right side of the heart. In Turner, IQ is normal. In Noonan, IQ is decreased. In Turner, we know monosomy. There is infertility, amenorrhea. Infertility is there. In Noonan, fertility is preserved, but it's usually subfertility. Males have what? They have cryptorchidism, that is undescended testes. Apart from this, another important sex aneuploidy, So whenever there is a problem in the sex chromosome, it's called sex aneuploidy. So Turner is a sex aneuploidy. You also have Klinefelter syndrome. Why does Klinefelter occur? Klinefelter occur because of XXY, and they look like this. So they will be what? They will be males with extra Y, extra X. They will be males with extra X. So they will have feminizing features. They will have what? Feminizing features. They will have breasts. That is gynecomastia. IQ will be low. They will be having tall stature. There is increased risk of having gonadoblastoma. Seminiferous tubules are destroyed. Hyalinized. And because they are destroyed, there is decrease in testosterone. And because there is decrease in testosterone, the feedback inhibition is lost. Because of the loss of feedback inhibition, there is increase in FSH and LH. in Klinefelter syndrome. And they will always be infertile. Because the seminiferous tubules are destroyed. So there are no seminiferous tubules. There's no proper semen production. Now let's see the question. A tall male presents with absent pubic hair, high LH and FSH, and XXY karyotype. What is the diagnosis? The answer is Klinefelter syndrome. And let's see this question. Most common cardiac anomaly associated with Noonan syndrome. Answer is going to be pulmonary stenosis. So here the answer is Klinefelter syndrome. Here the answer is pulmonary stenosis. Okay, Klinefelter syndrome and pulmonary stenosis. All right. The last very important topic that I'm going to discuss for you, the last very important topic I'm going to discuss for you is Tetrology of Fallot. TOEFL, they love asking questions related to TOEFL. They love asking related to questions of TOEFL. What are the 4 components of TOEFL? What happens in TOEFL? So let's discuss a little bit about TOEFL. Let's discuss a little bit about TOEFL. Now, as far as TOEFL is concerned, what is the main problem in TOEFL? What is the main problem in TOEFL? And that single main problem in TOEFL, that one main problem in TOEFL leads to everything else. The fundamental problem in TOEFL, the fundamental problem in Tetrology of Fallot is this. There is pulmonary, subpulmonary stenosis. Below the level of pulmonary wall, that's why it's called subpulmonary stenosis at times, there is subpulmonary stenosis. Now what happens because of this pulmonary stenosis? Whenever there is pulmonary stenosis, what will happen? The right ventricle will try to pump the blood. The right ventricle will try to pump the blood into the pulmonary artery, but it will not be able to do so because the pulmonary artery is stenosis, there is pulmonary stenosis. So the blood wants to go there, but is unable to do so. In response to this pulmonary stenosis, what's going to happen? Right ventricle tries to pump the blood. It will undergo hypertrophy. So that is the second component of Tetralogy of Fallot. There is right ventricular hypertrophy. So that is the first component is what? There is pulmonary stenosis. This pulmonary stenosis will lead to what? The second component, that is right ventricular hypertrophy. Now, the blood which is there in the right ventricle, it wants to pump the blood into the pulmonary artery. It's not able to do so. So what does God do? God makes a huge hole here and sends all the blood from right ventricle into the left ventricle via a huge VSD. This is the third component. There is a huge VSD and all the blood will go from right ventricle into the left ventricle. There is going to be, through this VSD, there is going to be a right to left shunt. And if the right ventricle blood goes into the left ventricle, the deoxygenated blood is going into the oxygenated side. This will lead to cyanosis. Now, when there is a huge VSD, when there is such a huge VSD, what's going to happen? The aorta will arise from a common left and right ventricle. All right. What happens? There is a huge VSD. So there is a right ventricle and left ventricle, but they appear as if they are a common chamber. And this is aorta. So aorta doesn't seem to arise from left ventricle. It arises from a common right and left ventricle because there is a huge VSD. This is called overriding of aorta. Because of this huge VSD, this is called as overriding of aorta. So the third component is VSD, and because the VSD is huge, this leads to overriding of aorta. These are the 4 components of Tetralogy of Fallot. In Tetralogy of Fallot, you will see on X-ray, you will see a boot-shaped heart. On chest X-ray, you will see a boot-shaped heart. Now tell me, what will be the cyanosis dependent upon? The cyanosis will be directly proportional. See, what's the main problem in Tetralogy of Fallot? The main problem is pulmonary stenosis. More the pulmonary stenosis, more the right ventricular hypertrophy, more the right to left shunt. Less the pulmonary stenosis, less the right ventricular hypertrophy, less right to left shunt. So the cyanosis will be dependent upon how much pulmonary stenosis is there. If there is more pulmonary stenosis, more right to left shunt will occur, more cyanosis is going to be there. So cyanosis is directly proportional to pulmonary stenosis. Cyanosis is directly proportional to pulmonary stenosis. So this is what's going to happen in Tetralogy of Fallot. Let's see the questions they had asked. Let's see the simple questions that they had asked. All of the following are components of Tetralogy of Fallot except. All of the following are components of Tetralogy of Fallot except. Tell me the answer. All of the following are components of Tetralogy of Fallot except overriding aorta. So let's write that down. Pulmonary stenosis leads to right ventricle hypertrophy. There is no blood which can go from right ventricle to pulmonary artery, so there is a VSD. Because there is a VSD, there is overriding of aorta. Overriding is there, pulmonary stenosis is there, VSD is there. This is not there. So the answer is going to be option D. Answer is going to be option D. Answer is going to be option D. Now, all of the following statements are true regarding TOF, except all of the following statements are true regarding TOF, except. Now, this is an interesting. I'll change the options. Let me change the options. If they give you this question, tell me the answer. If they give you this question, tell me the answer. This is a tough question. This is a tough question. I'll explain it to you right now. Excellent. Everyone is able to answer it correctly. Answer is going to be ASD. Answer is going to be ASD. See, sometimes in TOF, what happens? There is a PDA. Sometimes in TOF, there is a PDA. This allows some blood from aorta to go into pulmonary artery, resulting in lesser amount of cyanosis. Sometimes it occurs, not always. Sometimes a PDA can be there. It's not a component of TOF, but PDA can be seen in Tetrology of Fallot. This allows some amount of blood. To go from aorta into the pulmonary artery. Because more blood is going into the pulmonary artery, cyanosis will decrease. Alright, so this is sometimes seen. ASD is never seen. ASD is never seen in TOF. So answer is going to be ASD. ASD is never seen in TOF. ASD is never seen in TOF. Now, tell me what is going to be the answer. Severity of cyanosis is best decided by. Severity of cyanosis is best decided by. Severity of cyanosis is best decided by. Tell me the answer. Tell me the answer. Severity of cyanosis is best decided by. We have discussed this. Exactly. The answer is going to be option D. Right? Answer is going to be option D. More the stenosis, more the right ventricle hypertrophy, more the right to left shunt, more the cyanosis. So pulmonary stenosis is directly proportional to the amount of cyanosis. Higher the pulmonary stenosis, more right to left shunt, more cyanosis. So the answer is going to be subpulmonary stenosis. Severity of cyanosis in Fallot physiology is decided by subpulmonary stenosis. Alright, it's decided by subpulmonary stenosis, not VSD. It's dependent upon subpulmonary. More the stenosis, more the right to left shunt. More the stenosis, more the right to left shunt. VSD is just a conduit. Through VSD, the right to left shunt will occur. But the dependency, the amount is going to be dependent upon stenosis. More the stenosis, more the right to left shunt, more the cyanosis. Alright, more the cyanosis. With this, we complete today's session. Alright, we have discussed the most important topics. These are topics which are asked again and again and again and again and again. So you can be assured that if 10 questions are going to come from pediatrics, at least 5 questions will be from these kind of topics. At least 4 to 5 questions. At least 4 to 5 questions will be from these topics which we have discussed, and discussed the MCQs related to them, the important PYQs, some new questions also we have discussed. Alright. If you want to know about this, I will tell you breastfeeding and breast milk jaundice. Just give me a moment. In breastfeeding jaundice, there is inadequate breastfeeding. This inadequate breastfeeding leads to dehydration, and this dehydration leads to jaundice. Breastfeeding jaundice. Breastfeeding is not being done. In breast milk jaundice, there is a problem in breast milk. Breast milk has high amounts of beta-glucuronidase. This beta-glucuronidase will convert conjugated bilirubin into unconjugated bilirubin, leading to increase in neonatal jaundice. But remember, even in breast milk jaundice, although there is a problem in breast milk, it is not a contraindication to breastfeeding. You will continue breastfeeding. You will continue breastfeeding. So this is the important difference between breast milk jaundice and breastfeeding jaundice. Breast milk jaundice and breastfeeding jaundice. All right, we are done with this question. So one last question they asked. Thank you. I hope you enjoyed the session. Thank you. You have been a lovely audience. You have been a lovely students. This is just the last thing that I will say. The last thing I will say, all the best. I wish every single one of you will pass. I know every single one of you will pass. Give everything over the next 1.5 months. 1.5 months. Put everything that you have. Every single, तुम्हारा जर्रा बोलना चाहिए कि मैं इस बार पास होके दिखाऊंगा. और पास भी क्या, मैं 150 क्या, मैं 200 के ऊपर लेकर आके दिखाऊंगा. अगले 1 महीने जी जान से मेहनत करो, 100% पास होके. ठीक है? ऑल द बेस्ट. ठीक है?